Jerry Shields has done more for the field of choroidal melanoma or uveal melanoma than anyone else on the planet. His entire career, 40 years of practice, has been dedicated to the diagnosis and management of uveal melanoma. He has taught more doctors in America and internationally how to diagnose and how to handle this cancer. I see in the back we have some of the doctors working with us from Egypt, from India, from South America, from Italy, and these fellows come from all over the world to learn from Jerry and from our team. So I really would like to thank him for all that he's done for the field. The doctors will tell you he does occasionally get under our skin, though. But we'll still keep him. Anyways, my topic is the game of uveal melanoma, clinical features and management. I'll focus on management of melanoma. I'm going to cover a few points. First, I'll talk a little bit about causes of uveal melanoma. So there are host factors and there are environmental factors that have been found that can cause melanoma. One host factor is nevus. I have a nevus in my eye. Nevi carry a very tiny risk for transforming into melanoma. Ganley estimated 1 in 4,000 transform. Singh estimated 1 in 8,000 transform. Cavella said, well, if you live to be 80 years old, 1 in 100 transform. I'm planning on living to be 80, and this worries me. There have been other studies looking at nevus, population-based studies and clinic-based studies. I won't get into that. When we look at a nevus, we can tell immediately if it's a nevus or if it isn't. On the left is a nevus. It has this overlying drusen, age spots on the surface that tells us that nevus has been there a long time. On the right looks the same size, not a nevus. It's a small melanoma. Looks like a nevus, has pigmentation, but you can see on the surface we have orange pigment and a little blister of subretinal fluid. Even though these two lesions look a lot alike, one is bad and one is good. We've looked at choroidal nevus transformation into melanoma. Our focus on the oncology service here in Philadelphia is one thing: early detection, because we don't have good systemic therapies yet, but we hope to have them in the near future. So early detection is important. And as Jerry mentioned earlier, we use a mnemonic to find small ocular melanoma using helpful hints daily. Every resident in training, every doctor in America, and now worldwide, knows this mnemonic on how to find melanoma early, because they look a lot like a nevus when they're small. And so you can look at this tumor, and you can see it has a lot of risk factors that should be treated promptly. So we don't wait anymore for tumors to grow and produce blistering subretinal fluid. This is a lady who was watched for 5 years, and the tumor just grew and grew, and then she was sent in. She should have been sent in earlier. The other condition that can lead to the development of melanoma is melanocytosis. This is a congenital birthmark. We've looked at the risk. If a patient has melanocytosis, 1 in 400 will develop a melanoma. Melanocytosis is congenital pigmentation on the surface of the eye. It gives kind of a gray-brown look to the front of the eye, and it can produce little tiny melanomas in the back of the eye that need to be treated. And it doesn't even need to involve the whole eye. We looked at sector melanocytosis, where it only involves a little bit of the back of the eye, this part of the eye spared. This part that's pigmented at risk for melanoma. Here's another case. There's the melanoma. You have to look carefully if you have melanocytosis. It can even involve the iris, this congenital birthmark called melanocytosis. So that area that's pigmented is at risk for melanoma. And here's one, a patient from overseas that was sent in with melanocytosis and a little melanoma. So you have to be aware of some of these congenital conditions that can lead to melanoma. Now there are host factors, other host factors. If you look at our waiting room, which is primarily a waiting room filled with patients who have melanoma, you're going to see a picture like this. A light-eyed, fair-skinned patient with inability to tan. These are the host factors. So you look at me, I am a patient a person who could be a patient with melanoma, fair-skinned people. And if you look at environmental factors that can lead to the development of melanoma, and this has been done several times, there's one factor that keeps coming up over and over in studies, and that is arc welders. They are at risk for melanoma. In fact, we have one or two that have had melanoma in both eyes, so that's important to know. Now, I won't say much about features of melanoma because Jerry went through that. Basically, I just want you to understand melanoma can be small, it can be intermediate, as you see in this picture, and you can see the tumor's a little bigger on the ultrasound, and then it can be very large. So we classify melanoma into small, medium, and large. Therapy for melanoma. There's many different treatments for melanoma depending upon tumor size, tumor location, what the opposite eye looks like, how old is the patient, is the patient in good health, and what does the patient really want to have done. We always try our best to keep one goal in mind, survival. Our treatment is geared to saving the patient's life. Then we consider saving the eye. Then we consider vision as our third concern. But basically, if you have a small melanoma, we treat with a laser called thermotherapy or radiation, and we use plaque radiation. If you have a medium melanoma between 3 and 8 millimeters in thickness, we use usually radiation. Sometimes we can cut the tumor out of the eye, called resection, and sometimes we have to remove the eye. If you have a large melanoma, we sometimes can use radiation. Most often we have to use enucleation. I'll talk about radiation because radiation is used in our practice in about 85% of patients. It's the most common way to treat uveal melanoma worldwide, radiation. And we use radiation implant called plaque. And we use radioactive iodine seeds. And this is what the plaque looks like, 2 different types of plaque. We give a dose of 8,000 centigrade. That is a very high dose of radiation. It's double the dose you give for breast or lung cancer. And many different types of plaque for different types of tumors. And here you can see the plaque on the eye. It's placed surgically on the eye, and it's left in place for about 5 days. Here's a small tumor right next to the disc. We placed a special plaque called a notched plaque, and then the tumor, as the patient comes back, the tumor shrinks down. We're left with a flatter scar, and this patient has done well with complete regression. Here's another patient who had a melanoma near the optic disc, treated with plaque treatment, and in this case, we got rid of as much pigment as possible with TTT. And I can talk about this later when we use TTT, which is transpupillary thermotherapy. Some examples showing before and after plaque treatment. Again, before and after plaque treatment. Plaque treatment is successful in 98% of cases. It works all the time. 2% of patients show recurrence. The problem with melanoma is not control of the eye. The problem with melanoma is microscopic metastasis at the time you're sitting in the chair meeting your doctor that aren't visible to the doctor or to any blood tests. But as far as control of the eye, we've got that down pat. Those tumors that are right next to the optic nerve, that is in the back of the eye, real close to the nerve, these are really hard to treat. They're the hardest ones that we treat. I just want to show you how we do our treatment. If we look at this tumor, we have to measure it very precisely. We measure it that way, it's 8 millimeters. This way, it's 6 millimeters. Ultrasound shows it 2.9 millimeters. And then we give a radiation field that encompasses the entire tumor and 2 millimeters on each side. So we irradiate the entire tumor and a little bit of a rim. And our plaque is placed in the back directly over the area where the tumor is, and again, giving a 5-day radiation treatment. Here's an example before and after of these very difficult juxtapapillary tumors, and another one, larger nodular melanoma, treated with plaque radiation. I'll say a few words about the Collaborative Ocular Melanoma Study. This was a national study in America. It's completed. Many different papers came out. I'm not going to go through all the different reports, the first 15 reports, and the next 30 reports. But it did teach us a few really important things. This was a prospective study, and a very important prospective study. The first point the collaborative ocular melanoma study taught us was for medium-sized melanoma between 3 and 8 millimeters in thickness, plaque radiotherapy provide the same prognosis as enucleation. So removing the eye is not necessary for a medium-sized melanoma. And for large melanoma that usually comes to enucleation, that is over 8 millimeters in thickness, you don't need to give any form of radiation before you remove the eye. That's basically what it taught us. Last, prognosis. There have been reams of papers on prognosis of uveal melanoma. Basically, we do know that melanoma can be a deadly eye cancer. And I know this is a very sensitive subject, but we have to talk to you about this. There's a lot of literature on melanoma and prognosis. There are clinical factors, there are pathology factors, there's cytology factors, and there are genetic factors that predict who is at risk. I'm not going to go through specific papers. I'm just going to go through one important paper that actually came from our department that gives us a little meat on how to estimate prognosis. We published in 2009 a paper entitled Metastasis of Uveal Melanoma, Millimeter by Millimeter. Every millimeter counts. So when the patient is looking at the doctor in the office, all you have as the doctor when you're seeing that patient on the first visit is you know the tumor location and the tumor size. And based on tumor size, each increase in millimeter in thickness of uveal melanoma increases the risk for metastasis. So every millimeter adds a 5% risk for metastasis at 10 years. So if you have a 2 millimeter thick melanoma, it's about a 10% risk for metastasis. If it's a 4 millimeter thick melanoma, 4 times 5%, it's about a 20% risk for metastasis at 10 years. So what do we need to do about this? What we need to do about this, knowing these risks, is find a good medicine so that when the patients come to see us in the office, we treat their eye with radiation or whatever, and then we give them a medicine that can reduce their risk or incidence of potential future metastatic disease. So early detection is really important. Here's a melanoma that's 5 millimeters in thickness and has a 25% risk for metastasis by 10 years. This 10 millimeter thick melanoma, 50% risk. 1 millimeter thick melanoma, 5% risk. 2 millimeter thick, 10% risk. Again, greater than 10%, greater than 10 millimeter thick melanoma, greater than 50% risk. So it goes on and on. So we know who's at risk just based on thickness. So I'll stop at this point because I know my time is up and we need time for questions. And this is a lead-in for Dr. Sato, because Dr. Sato is going to talk to you about adjuvant therapies so that these patients who have thicker melanoma or who have genetic mutations, there are some alternatives that he and others have looked into that might help prevent or reduce the risk for metastatic disease. Thank you.
So that's the reason why we chose Sutent. And we did a pilot study, and that is has an interesting result. And currently approved for the kidney cancer and then GIST, and then I think neuroendocrine tumor recently. So, and then we did this, use this for the stage 4 patients. We only have one regression. Majority patient has stable disease for several months. And some patients have the medicine more than 2 years. Several patients have more than 1 year. These patients failed previous treatment. So we thought that the Sutent is doing something, and then just stopping at-risk growth for some mechanism, because c-KIT expression is not correlated to the good response. So we are kind of lost right now, which receptor is attacked, maybe PDGF or different kind of receptor, or anti-angiogenesis or immune response. But the fact is that this medicine may be doing something. This expression of the c-KIT, I would say 80%, 90% patient metastasis has activation. And this is one patient who has actual response. Actually, this patient did very long. And then with Sutent and others, we see the shrinkage. So since Carol and Jerry started sending me a patient with monosomy 3 HQ amplification, oh, Jesus, this is a challenge, And then I could say, okay, you might be in the 30% and try to be optimistic, but patient doesn't understand, say yes, okay, doctors have to give me something. And at that time, we just kind of finished up the, stage 4 disease patient trial. And then that is only one medicine that I'm confident to give. So therefore, okay, if you want to try this, just try this medicine. And then from clinical trial, we learned that patient cannot tolerate standard dose 50 milligram. 50 milligram, 4 weeks on, 2 weeks off, even 37.5 milligram every day. 2,000 patients say, I can't take any more in 2 months. So therefore, we decided to choose the lowest dose, which may be most likely efficacious, that the 25 milligram half dose. The idea is try to give this medicine for as long as possible to just prevent new vessels, potentiate immune system. So we decided to choose 25 milligram. And the idea is, blocking, c-KIT or other growth factors signal, and then try to induce anti-angiogenic. But if cancer cannot make any vessels, they cannot grow. They eventually immune system kicked in and then wipe them out. That's a concept. And again, this is not clinical trial. This is patient-based discussion and the insurance approval. It's a long, time-consuming process. But I'm getting old. We have like 5 or 6 years already. And then we have like almost 40 patients. But if we include a patient who is just finished, I can intentionally increase the response rate. So you understand? If in 10 days, 100 patients is there and 100% response rate, right? So therefore, we decide to choose the patients who are living matured. So we retrospectively, check the chart, medical record, and then collect the information. Actually, but this is like a discussion that we made. I only give a medicine for the patient who has higher risk. So monosomy 3 HQ amplification, large tumor, and the monosomy 3 plus, okay, and the other factors. And then we give a medicine, 25 milligram, as I mentioned, in 6 months. And then we keep checking. After 6 months, patient is very tired and sick, and then have some side effect. All right, we have 23 patients. The fact is we still have 8 patients who recur in this population. And then the important thing is, observation may be short, but after 2 years, nobody has recurrence. So small fraction patient has a recurrence, but if patient past 2 years mark point, probably we might cure the patient, or we are doing something good. This kind of, I have to just skip it. This is a similar population which is published in the paper, large tumor, monosomy 3, it's enucleated eye. Our group is here. And then again, there are many patients here, so we have to wait a little bit longer, but I think at least we can say this side effect, most of the patient has changing hair color and diarrhea, fatigue, hand and foot syndrome, but it's relatively mild. And then sometimes we have to give a break, but the majority of patients finish 6 months. In conclusion, so adjuvant suitent does not stimulate progression. That's one of the criticisms when we start. If you block the best cell formation, tumor may be aggressive. But it didn't happen. So this patient has a benefit compared to more than 50% recurrence in expectation. This patient, has better survival. So again, we have to do the formal clinical trial, increase more number. Interestingly, similar trial approach has been done by my friend on the other side of the coast. This is Dr. McRae, and then he has been done tamoxifen cisplatin, so therefore he combined this with sunitinib. And then as eligibility inclusion criteria is very similar. Then I sent the email, and then he kindly sent me a response quick. This regimen, chemotherapy for 4 months with suitent. It's a higher dose. He said a total of 9 patients enrolled, 2 patients has recurrence, small number of patients, so therefore he cannot make any conclusion. However, same thing, this probably doesn't introduce progression. Now, probably Dr. Gutman is going to talk a little bit more. Histone deacetylase inhibitor, this is related to BAP1. BAP1 is lost, that's an suppressor gene. That cause the dysfunction of the histone. So if you use a histone deacetylase histone acetylation inhibitor, HDAC deacetylation inhibitor, we might be able to correct the some abnormality. I'm pretty sure he's going to talk about that. So this is a BRCA1 associated protein 1 located in 3p21 chromosome 3. So this is important. So if you have a partial chromosome 3 deletion, I usually look into that, whether this is 3p21 or not. That's if they give us, And then this might be a loss of that gene sequence may, make the tumor, easy to break the gel. We call it a jailbreaker. But anyway, importance of that is not completely understand. But this is a valproic acid. This is done by Dr. Herbert's group. If he give a medicine to the mouse, still mouse stage, and then the progression is slowed down. So therefore, type of HDAC inhibitor may be beneficial in patient who has metastasis or who may have a metastasis, but stage 4 disease has not been treated. There is a clinical trial, so-called SAHA, SAHA, or at the Sloan Kettering. So we may know whether that is good or not. A couple of clinical trials. This is Triozzi from Ohio, Cleveland Clinic. This clinical trial, adjuvant trial, is closed for the accrual. This is chemotherapy with interferon alpha. We don't know the result. Again, this I mentioned, photomastine, intravenous infusion. We don't know the result yet. But again, we are getting more attention. So therefore, we might see some better results in the future, and then that could be available to you. Summary. Genetic and then molecular tests are now available to predict the risk of systemic recurrence. The major challenge is the absence of the curative treatment right now. So although various palliative approach with potential survival benefit has been developed. So adjuvant treatment to decrease or delay systemic metastasis need to be developed with scientific rationalization and justification. So I'll just mention my team. I think if you're here, Jefferson team, could you stand up? Yeah. So I'm just talking medical oncologist, but there's many. So this is teamwork. This is teamwork. We have a, Karin, stand up. Interventional radiology. Yeah. So this is Center for the Ocular Melanoma. Okay, I'm pretty sure we will be the first or second to find a cure. So So please keep putting pressure on us, keep giving us information, your idea. And finally, I want to just say thank you to all kind of family and patients who support our activity and then research. Thank you.